Welcome back, guys. Now in this video, let's start our lecture with the cardiovascular system. Now in this video, let's see the basics of the cardiovascular physiology. First of all, let's discuss about how many types of tissues are present in the heart. We are all having that one heart, right? Now in that heart, the tissues are mainly divided into how many types? The tissues are divided into nodal tissues as well as the muscular tissues. Okay, nodal tissues and muscular tissues. What are the differences between a nodal tissue and a muscular tissue? See, under nodal tissues, the examples are SA node, AV node. Okay, SA node, AV node, bundle of his Purkinje fibers, all of them, they are considered as the nodal tissues. Now, what is the property of these nodal tissues is that they generate action potentials. Okay, it's one single word, it generates the action potentials, which means SA node, it can excite on its own. Okay, it can depolarize on its own and it can generate an action potential, and it can even spread these action potentials to the other cells for the purpose of depolarization. In the same way, even AV node can generate the action potentials, bundle of His can generate the action potentials, and even Purkinje fibers will also generate the action potentials. But the frequency of action potential duration changes with every nodal tissue. For example, if I am talking about SA node, it generates maximum frequency of action potentials, that is 60 to 100 action potentials per minute. So SA node, it will produce the action potentials, maximum number of action potentials. AV node also produces the action potentials, 40, okay, something like that. And even bundle of His also produces the action potentials, 30, and even Purkinje fibers also produce the action potentials, 20 or 15. So what I am saying is, under nodal tissue, there are four important structures present: SA node, AV node, bundle of His, Purkinje fibers. All of them, they will generate the action potentials. Okay, they will undergo depolarization on their own. Under muscular tissue, which tissues are there? See, muscle is present in the atria or not? Yes, atria are contracting, right? Atrial systole will happen. So the muscles which are present in the atria, the myocytes which are present in the atria, and the myocytes which are present in the ventricle, they are accounting for the muscular tissues. They are coming under the muscular tissues. And these muscular tissues are helping in what? They are helping in the contraction of the heart. Okay. Now, after seeing the two basic types of the tissues in the heart, now let's see the action potential pathway. Okay, the basic thing which I want you to know is the action potential pathway. Where the action potential is going to start and where it is going to come and where it is going to stay for a certain amount of time, and how this action potential is going to spread to the ventricles, and how ventricular systole will happen, how contraction of the heart will happen, that we will see now. Okay. Now see, SA node. Let's start from the SA node. We all know that SA node is a pacemaker of the heart. It's a pacemaker of the heart. Okay. It controls the heart rate. Now, why SA node is the pacemaker of heart? Why not the AV node? Even AV node can generate the action potentials, right? Then why SA node is considered as the pacemaker of heart? Because it produces the maximum frequency of action potentials. Already I have explained to you, that is somewhere around 70 to 100 beats per minute. So maximum it is producing, so heart rate is under the control of SA node. Okay. So where the action potential have started? The SA node. Okay. Now what are the important points about the SA node? Maximum frequency of action potential generation, and it is considered as the pacemaker of heart. Next, let's talk about the AV node. The action potential from the SA node, it is coming down to the AV node. Okay, sir. Now what are the important points about AV node? AV node is considered as a relay station. Okay, AV node is considered as a relay station. Okay. Or it is classically called as the gatekeeper of the heart. AV node is called as a gatekeeper of the heart. Now why we are calling it as a gatekeeper of the heart? Because all the impulses which are coming from the SA node, all the action potentials which are coming from the SA node, they have to come to the AV node before they are entering into the ventricles. So action potential, before it's entering into the ventricle, it have to come to the AV node. And in the AV node, the action potential or this electrical impulse is going to stop there. It is going to wait there for a 0.1 second. For almost 0.1 second, the action potential is going to stop in AV node. Now you can ask me, sir, why the action potential is like getting delayed in the AV node for 0.1 second? It's because this delay is called as a AV delay. Okay, this delay is called as a AV delay. And what is happening? The impulse conduction is getting slowing down. Okay, the impulse conduction is getting slowing down in the AV node. So please concentrate. Slowest speed of conduction. Okay, slowest speed of conduction. How slow, sir? The impulse is moving with the speed of 0.05 meters per second. Actually, this is electricity, guys. Electricity will almost travel with the speed of light. Okay, it can travel with the speed of light. But in AV node, what is happening? This action potential is now only moving with a speed of 0.05 meters per second. So because of that, there is AV nodal delay. Okay, AV nodal delay. Now, why this AV nodal delay is happening and why this is important? Sir, this AV nodal delay is because that AV node have the least gap junctions. Okay, AV node, it have least gap junctions. Okay, let me write it down here, guys. Now, the slowest speed of conduction is because AV node have least gap junctions. Okay, it have the least gap junctions. So that's why the impulse is taking lot of time to go through the AV node. So it's going very slowly. Least number of gap junctions are present. Now, what is the importance of this AV delay? Importance is, now usually if you ask a normal student, a first year student, he will think that heart is contracting at the same time. Okay, atrial contraction, ventricular contraction are happening at the same time. Usually a first year guy who doesn't have a good knowledge on the cardiac cycle say something like that. See, your heart is not contracting like that. First, atria have to contract. It have to pump the blood into the ventricles. Then ventricles should contract. First atrial contraction, then only ventricular contraction. Atrial contraction, ventricular contraction. So at a time heart should not have to contract. First we need to contract the atria, then only ventricles. For example, if there is no delay, what will happen? The impulse is going to spread across the heart at a time. Okay, for example, think that there is no AV node. From the SA node, electrical impulse or the action potentials is going to spread in the entire atria and AV node at the same time. Why? Because this is already I have explained to you, this is an action potential, this is an electrical impulse. It will travel with the speed of light. So what I am trying to put into your mind is, if there is no AV node, the entire heart will contract at a time. Okay, that's something not good. So, in order to prevent the contraction of atria and ventricles at a time, in order to prevent, there is AV nodal delay. So, what is the importance of AV nodal delay? It prevents simultaneous contraction of atria and ventricles at same time. Now, what is the importance? It helps in ventricular filling. It helps in ventricular filling. So, what is this ventricular filling? See guys, what I have explained to you. First atria should contract, then only ventricles should contract. Okay, see, when the atria are contracting, what is the status of ventricles? Ventricles are relaxed, right? Ventricles are relaxed. So, when the atria are contracting, blood is moving from the atria into the ventricles. So, ventricular filling is happening, right? Yes. So, at the time atria are contracting, ventricles are filling. So, ventricular filling is happening. Okay, ventricles are not contracting because the impulse is now stuck in the AV node. So, ventricles are relaxed, they are receiving the blood from the atria. So, what is the physiological importance of AV delay? It helps in ventricular filling. Okay, now see, this delay is going to reflect in the form of PR interval. Okay, this delay, or I should say something like this. Impulse is started from the SA node. Impulse is starting from the SA node. Now the impulse, now it have to come to the AV node, and impulse have to pass through the AV node. All these events, okay, movement from the SA node to AV node and through the AV node, all these events are reflected in ECG, okay, in the form of PR interval, So, what is the duration of PR interval? 0.1 second, okay. Now, in the next slide, we will discuss about the PR intervals and different types of heart blocks. There, you can understand what is the importance of this. Sometimes, do you know what happens? The impulse, whatever is coming from the SA node, okay, it will come to the AV node, and in the AV node, it will be blocked. The impulse is going to be blocked. So, this is called as conduction block or heart block. See, you can have heart blocks in many regions. Okay, you can have heart blocks in many regions, but what is the most common site of heart block? The impulse got blocked, the impulse got terminated, and impulse is not moving forward. The most common site of conduction block is AV node. Okay, the most common site of conduction block is AV node. Now after this, see the impulse, now it's coming down to bundle office from the SA node, impulse came to the AV node, from the AV node, the impulse is coming down to the bundle office. From the bundle office, the impulse is going down to the bundle branches. Okay, left bundle branch, right bundle branch. We are having right ventricle and left ventricle, right? Now the impulse is splitting through the bundle branches, left bundle branch and right bundle branch. Now from the bundle branches, what are going to come? From the bundle branches, Purkinje fibers are going to come. Now these Purkinje fibers will go into the myocardium, which will stimulate the myocytes, so that myocytes will undergo contraction. Important point is that the Purkinje fibers, okay, the Purkinje fibers have the fastest speed of conduction. Okay, have the fastest speed of conduction. If you ask me why there is fastest speed of conduction, it's because of the presence of the maximum number of gap junctions. So in the entire pathway, maximum number of gap junctions are present in the Purkinje fibers. Okay, fastest speed of conduction is seen in the Purkinje fibers. How fast? 4 meters per second. Okay, impulse is traveling with a speed of 4 meters per second. So these are some basic points about the action potential pathway. Okay, now after saying this, let's see some important points about the ECG. Okay, we are not discussing in detail about the ECG. Okay, in the next videos, in the next upcoming videos, we will be discussing in detail about the ECG. What is P wave, QRS, T wave, okay, ST segment. We will discuss them. Now here, basic points are, see, here you are having the P wave. First of all, what exactly is ECG? ECG is a graphical representation of, it's a graphical representation of electrical activity in the heart. The electrical activity, not the mechanical activity. The electrical activity in the heart is represented in the form of ECG. The electrical activity in the heart is now we are just drawing the graph in the form of ECG. See, P wave, what exactly is this P wave represents? See, this P wave is representing that atria are undergoing depolarization. Words are important. I am not saying atrial contraction. Atrial depolarization. Now, atria are electrically depolarized. Okay, so atrial depolarization. Okay, now see, this is the place where, okay, this is the place where action potential have started. Okay, from the SA node, this is the point where exactly this is the starting of the P. So from the starting of the P, the action potential have started, depolarized the entire atria. Now the impulse is coming to the AV node. Okay, see, from the starting of the P to the starting of the Q wave, what exactly is happening? Now the impulse is now starting from the SA node, now the impulse is going to the AV node. So this interval, the interval starting from the P to the starting of the Q, this interval is called as the PR interval. Don't say PR interval is from the starting of the P to the R. No, starting of the P to the starting of the Q wave, this is called as a PR interval. Now again I am asking you, see in this PR interval what is happening? Now the impulse now is starting from the SA node, depolarizing the atria, going to the AV node and going through the AV node also, going to the and through the AV node. Okay, this is the PR interval. Now what exactly is QRS? QRS is the ventricular depolarization. Now the action potential, now it is going to the ventricles and depolarizing the ventricles, not contraction. Okay, see, contraction is a mechanical event after depolarization. Okay, here I am not talking about the mechanical events, here I am graphically representing the electrical activities in the heart. Okay, so QRS, what exactly is happening? The ventricular depolarization. Now after that what happens? Now what is T waves, sir? Are you able to appreciate here the T waves? Usually students, while they are drawing the ECG, they will show the P wave and T wave in the same form. No, T wave is little bit tall. Okay, T means tall. T waves are taller than the P waves. Okay, T waves are little taller. Okay, so what exactly is this T wave? T wave represents ventricular repolarization. Okay, ventricular repolarization. Now, ventricles are depolarized. Now they have to repolarize, no? Okay, so this is the depolarization of ventricles. QRS is the depolarization of ventricles and T wave is representing the repolarization of ventricles. Now you can ask me, sir, P wave is atrial depolarization, right? Then where is atrial repolarization? Here I am showing you atrial depolarization. Where is atrial repolarization? See, atrial repolarization happens during QRS. Okay, see the magnitude of QRS or the electrical activity which happens during the ventricular depolarization is more when compared to the atrial repolarization. So atrial repolarization event is not actually recorded in the ECG. So in the ECG you do not have any atrial repolarization, okay, which is exactly happening during ventricular depolarization. So atrial repolarization is not noted. Simple. Now T wave completed. T wave is representing the ventricular repolarization. Now after this, what are these U waves? Are you able to appreciate a very small wave which is not going to be seen most of the times? Okay, in most of the times in ECG you can't able to see this U wave, but this U wave is something absolutely physiological. This is not something pathological. This is something absolutely physiological. Okay, now this U wave is because of delayed repolarization of papillary muscles. In our heart there are muscles called as papillary muscles. From the papillary muscles, the chordae tendineae, they are going to the valves. For the opening and closing of the valves, chordae tendineae are there, right? Now this chordae tendineae are attached to the papillary muscles. Now these are muscles so that they can undergo depolarization and repolarization. Now the U wave, it is delayed repolarization, okay, due to delayed repolarization of the papillary muscles. Very small wave which is not usually seen, and that's something absolutely physiological. Okay. Now after discussing this, I just want to integrate PR interval here, okay, PR interval with the conduction blocks. Guys, we have already discussed what is the normal duration of PR interval. Please look here. PR interval usually it accounts for 0.1 second. Starting from SA node, impulse started from SA node, it have to come to AV node and you have to go through the AV node. The entire, how much time it will take? It will take almost 0.1 second, 0.1 second. Okay. Now, let's talk about heart blocks, guys. Okay, now let's talk about the heart blocks. Now, when we are going to consider there is heart block, when we are going to consider that there is a heart block. See, if PR interval duration, if it is becoming more than 0.2 millisecond, if it is becoming more than 0.2 milliseconds, then it is considered as the first degree heart block. Sir, what exactly is first degree heart block? See, there is PR interval prolongation. Normally this duration, okay, PR interval, okay, starting from the P to the starting of the Q, this duration should be just 0.1 millisecond. Okay, this duration should be 0.1 millisecond. If it is more than 0.2 milliseconds in the ECG paper, okay, here in all the conditions, the PR interval duration is now greater than 0.2 millisecond. Okay, of course, this is not an ECG paper, but what I am saying is if the duration is more than 0.2 millisecond, okay, then you have to say it as first degree heart block. Now you can ask me, sir, what is the cause of first degree heart block? Why this is happening? Now let me tell you in a very simple way. Okay, think that this is an SA node and here is the AV node. Okay, SA node and AV node. Now impulse have to go from the SA node and through the SA node. But think that here in this conduction pathway, there are certain obstacles present. For example, iron deposits or granulomas, okay, or something like ash of bodies, ash of nodules, okay, which are seen in rheumatic heart fever. So if there are any obstacles present in this pathway, okay, iron deposits. Now whenever the person is having iron overloaded state, that example is hemochromatosis. The patient now is suffering with a disease called as hemochromatosis, where there is over iron load. okay, where there is too much amount of iron present in the body. Now this iron is getting deposited here, and that iron is not letting, it's not letting the impulse to travel from the SA node to AV node fastly. So now it's taking lot of time. Instead of 0.1 second, now it will take a lot of time for the impulse to pass through. So this is considered as first degree heart block, In the same way, when the person is suffering with rheumatic heart fever, imagine usually rheumatic heart fever is going to be seen in those boys or girls of age 5 to 15 years. Okay, usually the age group is 5 to 15 years. Now, whenever the person is suffering with rheumatic heart fever, they are going to have what? Aschoff nodules in the heart, which are the pathognomic feature of rheumatic heart fever. Now, whenever these nodules are present in this area, again, it will take a lot of time for the impulse to pass from SA node to AV node. In the same way, sarcoidosis. Okay, in the sarcoidosis, the patient is going to have what? Granulomas. Okay, the patient is going to have granulomas in the heart. Now, here the granulomas are present, and these granulomas are not letting the impulse to travel from the SA node to AV node fastly. So, more time, that is first degree heart block. How much more time? More than 0.2 milliseconds. Now, if you ask me what is the treatment of this heart block, usually there is no need of any treatment. Okay, there is no need of any treatment. If at all they gave you a question, so which of the following drugs can be used in the treatment of first degree heart block, you can go with the atropine. Okay, you can go with the atropine. Now, why, if you ask me, sir, these are heart blocks, right? The heart block means what happened to the heart rate? Heart rate decreases. If I am having heart block, heart rate decreases. Now, what you have to do as a treatment? You have to increase the heart rate. So, what you are going to give? Heart stimulants like atropine. Atropine will increase the heart rate. Simple. Now, after discussing about the first degree heart block, now let's discuss about the second degree heart block. Okay. Now, actually the second degree heart blocks are divided into MBBS type 1 and MBBS type 2. Type 1 and type 2. Guys, now let's discuss about the second degree heart block, which is MBBS type 1. MBBS type 1, which is also called as a Wenckebach's phenomena. Okay, Wenckebach's phenomena or MBBS type 1 heart block. See here, where exactly the problem located? The problem is located in the node. Okay, the problem is located in the node. See, in the first degree heart block, the problem is not with the AV node. The problem is present in the pathway. Okay, in the conduction pathway between SA node and AV node. Now, what I am saying right now, in second degree heart block MBBS type 1, the problem is in the AV node itself. Okay, let me draw here. This is SA node. Okay, let me show it here. See, this is SA node. Here is the AV node. Okay, the conduction pathway is absolutely normal, but this AV node is not conducting the action potential properly. This AV node got damaged. This AV node got damaged because of some drugs or because of some toxins or alcohol. Because of some reason, the AV node got damaged. Okay, it's not allowing the conduction to go, or it's not allowing the impulse to go through the AV node properly, but still it is working. Okay, not complete damage, still it is working. Now, what happens? Sir, in second degree heart block, there is a progressive PR interval. Okay, there is a progressive PR interval prolongation of the PR interval progressively. But at a time, there is a dropped beat. Okay, progressive PR interval with a dropped beat. Now, what I am trying to put into your mind is, sir, the AV node is weak. The AV node is weak. Already weak, already damaged. Now, this person again started drinking. He started drinking. Okay, so that what happens? Now, again say, now first it's normal PR interval, 0.1 millisecond. Next what happens? Now PR interval starts to prolong. Now the patient is again taking some drugs or toxins, or he is doing binge drinking. Now AV node is again now getting affected. So what is happening now? There is gradually. First it is normal, little bit prolongation. Now again PR interval is prolonged. Suddenly there is a complete block. AV node stop functioning. There is a complete block. So what happens? Ventricles are contracting. So there is no QRS complex. Dropped beat means no QRS. Okay, no QRS complex. Okay. So in second degree heart block, where exactly is the problem? In second degree heart block, Wenckebach's phenomena or MBBS type 1, problem is intranodal problem. The nodes are not properly functioning. Which node? AV node is not properly functioning. Still it is working, but it's not dead. Okay. So if I ask you, is it that dangerous? It's not that dangerous. Why? Because there is no sudden dropped beat. Okay, there is no sudden dropping of the ventricular systole. So progressively, heart is now it has some time to adapt. Okay, it is not happening suddenly. So progressively it is happening. Okay, PR interval prolonged, sudden drop beat. So heart will undergo adaptation. Why I am saying this is because, say, in Mobitz type 2 heart block, okay, in Mobitz type 2 heart block, okay, which is also a type of second degree heart block. Now what happens is, see, there is a fixed PR interval with a sudden drop beat. Please look at here, the PR interval is constant, PR interval constant, PR interval constant. But if you look at, there is sudden missing of QRS complex, P wave, QRS, T, P wave, QRS, T, P wave, QRS, T. Now here P wave, where is QRS? There is no QRS, again P wave is starting. Okay, so there is a sudden dropped beat, ventricular asystole is the same. So this is second degree heart block, which is a very dangerous heart block. Now if you ask me, where exactly is the problem, sir? See, the block level is bundle of His or infranodal, not intranodal. This is infranodal heart block. Sir, what exactly is infranodal heart block? See again, here is the SA node. Okay, here is the SA node. Now, information have to go to, no, sorry, not information, impulse have to go to the AV node. Now from the AV node, who is going to come out? Bundle of His have to come out. Now this bundle of His will divide into left bundle branch, right bundle branch, and from here the Purkinje fibers will give the impulse to the ventricular myocardium. Now the problem is at which level? The problem is in the bundle of His. Now bundle of His is not sending the impulses down. Okay, so infranodal node is okay, no problem, but block is below the node, that is infranodal. Now if you ask me, what will happen, sir, here? See, normally the entire heart rate is under the control of SA node. Normally SA node should have to control the entire heart. Now here what is happening? Now SA node is okay, AV node is also okay. Okay, so SA node, it will control the entire atria. Okay, SA node is giving the impulses, so SA node, it will control the entire atria, no problem. Impulse is coming to the AV node and impulse is even going to the bundle of His, but from the bundle of His, impulse is not going into the ventricles. So now ventricles, are they going to contract or not? Yes, they will contract, no doubt, but not because of the impulse from SA node. Impulse from the SA node is blocked in the bundle of His. Now whenever there is a damage in bundle of His, now who are left? Which pacemakers are left? Okay, which pacemakers are left? Only Purkinje fibers are left, right? Only Purkinje fibers are left. Purkinje fibers, they can also act as a pacemaker. They can also produce the action potentials. But how much? Only 20 action potentials per minute. So ventricles, ventricular rate is now under the control of Purkinje fibers. Atria are under the control of SA node. Where is the block? Block is at the level of bundle of His. Okay. Now how many times the atria are contracting? Sir, atria are contracting on their own, ventricles are contracting on their own. But problem is, see, we are not concerned about the atria. Okay, we are not concerned about the atria. We are more concerned about the ventricles. Because, see, ventricle rate is now drastically falling down. Okay, only 20 beats per minute. Do you think, normally, what is the, how many times heart have to beat? Heart have to beat almost somewhere around 70 beats or 72 beats or 80 beats, that's okay. Okay, 60 to 100 beats, okay. Now the heart rate is coming to 20. Now do you think this person is going to have a normal cardiac output? Definitely not. Cardiac output crashes, BP crashes, the patient will die. So this Mobitz type 2 heart block, it is considered as a most dangerous heart block. Okay, second degree heart block, Mobitz type 2. So it is considered as the most dangerous heart block. Most of the students will think complete heart block or the third degree heart block as the most dangerous heart block. No, Mobitz type 2 is the most dangerous heart block. Okay, it can lead to sudden cardiac death. And important point is most common bradyarrhythmia post MI. Okay, usually post MI, post myocardial infarction, the patient will have arrhythmias. Okay, post myocardial infarction. If I am the person who is having myocardial infarction, after that, after having an event of myocardial infarction, the patient usually have arrhythmias, especially tachyarrhythmias. Ventricular tachycardia will occur. Okay, ventricular tachycardia will occur. Tachycardias are the most common arrhythmias. But if they ask you a question, which bradyarrhythmia is most common post MI? Which bradyarrhythmia? The most common bradyarrhythmia means heart rate is going down. The most common bradyarrhythmia post MI is again Mobitz type 2. Mobitz type 2, and here the treatment is temporary pacemaker. Temporary pacemaker. Okay, temporary pacemaker is the treatment. Why? Because you cannot go for the surgery also. The patient is having a very less, the patient is absolutely unstable, right? He is having very low cardiac output. The patient is having very low heart rate. So you cannot go with the surgery. So temporary pacemaker is the treatment. Now after this, let's discuss about the third degree heart block. Okay, now let's discuss about the third degree heart block or the complete heart block, which is also called as the Stokes-Adams syndrome. Third degree heart block, complete heart block, or the Stokes-Adams syndrome. So what now? Where exactly is the problem, sir? Again, the problem is in the AV node. Okay, so where exactly is the problem? The problem is in the AV node. What is the problem? AV node is completely dead. That's it. AV node is completely dead. It's not conducting the impulses. If it is not conducting the impulses, now P waves, sorry, not P wave. This is the SA node. Here is the AV node. Here is the bundle of his. Here is the bundle of his. Right bundle branch, left bundle branch. From that, who will come? Purkinje fibers will come something like this. Now, where exactly is the problem? The problem lies at the level of AV node. So, now what happens? See, the impulses whatever are coming from the SA node, now these impulses will control the atria. Okay, they will control the atria. Now, there is a block in the AV node is not functioning. Now, this bundle of his which can generate an action potentials of almost 40 beats per minute, okay, 40 beats per minute. Now, it is going to control the ventricles. Okay, so atria are controlled by the SA node and ventricles are controlled by the bundle of his. Now tell me, sir, atria, now how many impulses are coming? How many impulses are coming from the SA node? 100 impulses are coming. How many impulses are coming from the ventricles? How many impulses are coming from the bundle of his? Now bundle of his is only generating somewhere around 40 impulses. So normally speaking, there should be one P wave, one QRS and one T wave. One P wave, one QRS and one T wave. This is something normal. Please concentrate. Even before we have discussed, see, P wave, QRS, T wave, P wave, QRS, T wave, P wave, QRS, T wave. Okay, normal. This is something normal. It should be in 1:1 ratio. But here in third degree heart block, the number of P waves and number of QRS are not going to correlate. The P waves are going to be more when compared to the QRS complex. P waves are more than the QRS complex. P waves are more than the QRS complex. Now please look at here. Why P waves are more than the QRS complex? Why? Because SA node is generating the maximum number of action potentials. Now atria are under the control of the SA node. Now ventricles are under the control of bundle of his. Bundle of his can only generate 40 action potentials. So P waves are more. See, one P wave. Okay, see, again there is one more P wave. Okay, one more P wave, P wave, P wave, P wave. Okay, again there is one more P wave. So 1, 2, 3, 4, 5, 6, 7. There are 7 P waves. But look at the number of QRS complexes. There are only 3 QRS complexes. So this is something called as the AV dissociation. AV dissociation. Atria are contracting on their own. Ventricles are contracting on their own. Okay, atria are contracting on their own. Ventricles are contracting on their own. So this is called as AV dissociation. Okay, number of P waves does not coincide with the number of QRS complexes. So how to treat this condition, sir? It is a permanent pacemaker. Okay, permanent pacemaker with a dual pacing. Permanent pacemaker with dual pacing. Okay, with permanent pacemaker with dual pacing. So one lead will go to the atria and one lead will go to the ventricles. Okay, there is this permanent pacemaker. Like, one lead is going to come and attach to the atria and one lead is going to come and attach to the ventricles. So this pacemaker is controlling both atrial rate and ventricular rate simultaneously. Okay, so this is the treatment for third degree heart block. And AV dissociation, important point is, whenever you see this word AV dissociation, see, it should strike you either the person is suffering with the third degree heart block, or AV dissociation is also seen in a condition called as ventricular tachycardia. Okay, in a ventricular tachycardia also there is AV dissociation. So from now on, whenever you listen the word AV dissociation, two things should come to you in your mind. One is ventricular tachycardia and the other is complete heart block or the third degree heart block. Okay. Guys, we have discussed the basic important points, that is the different types of cardiac tissues, the action potential pathway, important points about the SA node, AV node, bundle of his, Purkinje fibers, and also we have discussed some clinical points, that's the heart blocks. We have also discussed about the heart blocks and causes and treatments. Hope the video is helpful. See you in our next video. Thank you.